Hello, I'm Mcmanus, the convener of the Convergent Science Network, and on behalf of its sponsors, I welcome you to this webinar, Transforming Mental Health, the Barwon region experience from wherever you are joining us. The Convergent Science Network regularly holds events such as this to discuss how multidisciplinary research from the biological and physical sciences, engineering and computing is shaping the future of healthcare. The network is proud to be partnering with Barwon Health and Deakin University to bring this event to you. Mental illness is a major social, health and economic issue, and this evening we look forward to bringing different perspectives on what we can do to improve mental health care. So let's begin. It's now my pleasure to invite Ms. Frances Diver, the Chief Executive of Barwon Health, to say a few words.
Good evening. Thanks very much, Luan. Thank you very much for the opportunity to introduce the session today. So firstly, could I start by paying my respects to the elders, the traditional owners of the land, the Wadawurrung people, and acknowledge any Aboriginal or Torres Strait Islander people here today. So firstly, I'm delighted to be introducing this session for a couple of reasons. One of the reasons I'm delighted is that we've got an impressive lineup of people here to have a really important conversation about mental health services, research, future directions, reforms, anything that anybody really wants to bring up. And I'm delighted that there is such a large group of people, both consumers, clinicians, academics, researchers who have joined us to have this really important discussion. The next thing I guess I would say about the session that I'm also really pleased about is it's really our first CHIME event, public event. And CHIME, a collaboration between Barwon Health and Deakin University, something we've established over the last 12 months or so, CHIME standing for Change to Improve Mental Health. And there's no denying that we need change to improve mental health in the community, but also change the way that we deliver mental health. So this really important partnership that we've developed will bring together hopefully the best minds and the best people, both consumers, families, carers, people in the community, as well as clinicians and academics, to make sure that we're delivering the best kind of services that we can in the community. We have a really strong reform program underway at Barwon Health, and CHIME will be a really important part of the changes that we want to make in our services. So I'm keeping my comments brief because there's very impressive people here that will be able to provide much more expertise in mental health. So thank you everybody for participating. Thank you very much for your contributions, and I look forward to hearing what people have to say. Back to you, Luan. Thank you.
Thank you very much, Frances. I'm pleased to introduce Renee Carolyn, the Interim Director of the Change to Improve Mental Health Centre of Excellence, CHIME, who will moderate this event. So over to you, Renee.
Okay, thank you, Luan. Thank you, Frances. And I'd like to thank the Convergent Science Network for hosting this event tonight. And welcome to everyone who is joining us today. As Frances has said, we have an extraordinary panel covering many perspectives of mental health and the mental health system. As she also said, I'm the Interim Director of CHIME, which is a newly formed partnership between Barwon Health and Deakin University in translational mental health research. The community awareness of the importance of mental health is becoming pervasive, but it is also widely acknowledged that the system is struggling to provide the services and outcomes that people experiencing mental illness need in order to heal. We are hopeful that by bringing all the voices to the table tonight, we can together drive meaningful changes. I'm going to introduce our panel tonight in three groups, being people with a lived experience of mental illness, either as a patient, a carer or a family member, practitioners and researchers, and last but not least, policymakers. We will hear from each group, and I will ask one or two of the registration questions before moving on to the next group. And then after the third group, I will open the event up to a broad audience question and answer. So please type in your questions into the Q&A function at any point of the event, and I hope to cover as many of them as possible. If we are unable to get to all of your questions, we will post an FAQ sheet with responses to common questions on the Chime website a couple of weeks after the event. And just to let you know, if any of the discussion tonight raises issues for you, details of where to seek support will be available during the event in the chat function. So on to the event. I'm pleased to introduce you to our first panel members, James Mcclure, Marta King and Tony Mcmanus. James currently works as a senior peer support worker at Barwon Health and has personal experiences of the mental health system in the Barwon region. James, are you able to kick us off tonight by telling us a bit about your experiences, what that means in terms of your role at Barwon Health, and what do you think is the most important thing that needs to happen to transform our mental health system?
Sure, Renee. Thank you. Good evening, everyone. I'm James Mcclure. I've experienced a 7.5-year mental decline, becoming prey to delusion and hallucination. After experiencing the most disturbing thoughts, I sought help and started a healing journey in the Swanston Centre. Over the last 14 years, I've experienced daily personal growth and have dedicated myself to playing my part in the healing of others. At this point, I'd like to share Rose's principle of universal benefit, and that is that each person's recovery or personal growth aids in the transformation of the world. So that's where I see we can start transforming mental health through the individual. GROW, for those that don't know, is a mental health movement, peer support, founded in Sydney in 1957. In transforming, an undervalued component is the effort of the person and their recovery and their family. So for me, in years 2 to 5 of recovery, I was working 15-hour days, 7 days a week, fighting the disturbing thoughts I was having. Disturbing thoughts for every 3 seconds, all day, every day. It was absolutely relentless. And I needed to be absolutely relentless in fighting. By fighting and capturing and nurturing moments of ordinariness, this very slowly became every 4, 5 and 6 seconds. And that was on the right medication for me. My parents, Daryl and Leisha, provided a loving, hope-filled and fun home conducive to growth. I equate that early recovery as being 90 times harder than doing an AFL pre-season, albeit one of the ones I did back in the 90s. No one told me until I got to GROW that post a mental decline, there's a new self that emerges. And that's the beginning of a new and improved you. And that growing to mental health will change my life for the better. And that's the hope that peers can provide for each other. The hopes I had early in recovery that seemed as I was sleeping 18 hours a day have now been realised. I have a completely gorgeous fiancée, Emma, our 2 boys, Sam and Jude, and a family home that we live in. This is where I believe the efficacy of peer work becomes an essential component of the mental health system. And we've begun it, and it needs expanding. Back in the 1790s, Philippe Pinel, the physician, insightfully described peer workers as gentle, honest, humane, and disposed to kindness. These qualities, I believe, hold true for peer workers today. As equal companions in peer support, we learn from each other, heal each other, and support the development of the new self in one another. We are a blessing to each other. Some of the feedback we get as peer workers includes, it's so great to speak to someone that gets it. I'd like to see a system where every interaction counts. The people that come into our care are met with hope and the belief that they will prosper and grow, and that the best in life and love and happiness is ahead of them. Mental health professionals who themselves are personally growing are so important because transforming people transform people. We need to use person-centred, growth-oriented language at all times. And just finally, it can be a blessing to go through a mental decline and then connect with daily personal growth as it humbles us, realigns our values, and helps us to become the people we're sent to be. That is, gentle builders of a free and whole community. Thank you, Renee. Back to you.
Thank you so much, James. So Marta King works as a carer peer support worker at Barwon Health and has personal experience caring for family members with mental illness. Marta, can you tell us what a carer peer support worker is? How did you get there, and what do you think are the most important changes that need to be made?
Hello everyone. So, how do we transform mental illness? I believe in the philosophy of care as being more informed, valued and involved in the care of their loved ones. I believe this should not be a privilege or a bonus, but a carer's right. If we can work together, the workforce, consumer and carer, it's more likely to benefit all parties. Carers are involved because, well, they care. Give carers informative support and let them know their involvement is important. The community should seek to address mental health in a way that they are all responsible for the health and well-being of the unwell. Here are a couple of the ways I look at it when I explain what I do as a peer support worker. A bare tree may be perceived as beyond help. For the gardener, it can be difficult to know what they can do. But others with experience and knowledge can reassure and guide the gardener to help that tree recover to the tree that it's supposed to be. We can think of it as like a dance where we move together, committed to get to a better place. Flamenco is a strong and passionate dance form. It requires you to give of yourself entirely, give of your heart, duende. It requires you to show emotion and connect. This is of your movements. Without this commitment, it can end up just like a bunch of steps. No single part, emotion, use of body and rhythm are more important than the next. The idea of connection helps me to engage with carers. Peer support works well, extremely well. For instance, there was a time where I met with a carer who I could see was visually quite upset, and I introduced myself and said what I did, and he was like, no, I'm okay, just look after my unwell family member. And I said, well, it's okay, look, this is what I do, and I spoke about my journey in mental health. That led to a walk around the block of the hospital a couple of times. We sat down at a bench and we spoke for another while. This led to an appointment the next day with his sister-in-law so that we can meet up at a family meeting. And then we debriefed afterwards. So in all likelihood, he really did need support, but he felt it was the last thing he needed. And at the end, he was so grateful, and he connected with me on such a level that he was felt a lot less anxious and felt empowered to deal with what was going on. So, and this sort of support, it would be great to be able to offer this to all carers at some level. There's a natural understanding and an ease of conversation that comes from talking to someone who really gets it. If we don't include the carer in the equation of helping people move to better health, we risk not helping or getting the full picture, all the benefits of engaging the carers. Carers need to feel connected to their loved ones. They need to and must be heard. Carers will often hold little nuggets of information and insights that their loved ones illness. And don't forget, many of them are expected to follow up the care of their loved ones. Some carers can find themselves out of their depth. They can also feel overwhelmed and anxious. They may also be dealing with their own mental health and physical illnesses. So please be gentle. Acknowledge carers and their journeys in their own right. Carers whose loved ones has experienced their first admission in acute care, this is even more important. and a passion of mine. A quiet, safe and dedicated space for families and carers would help. I wonder how many people working in mental health have ever noticed a carer taking a breath, a pause to gather themselves before entering a ward or a family meeting. If you haven't, take a closer look. Carers play a big role in helping their loved ones to get better. Let's acknowledge this. Let's involve and support them, and let's tap into their experience and insight. Thank you. Thanks, Renee.
Thank you, Marta. So Tony Mcmanus is next, and Tony has a personal and family experience with mental health issues. He is a passionate advocate and mentor for people experiencing mental health problems, and he has his current role as the National Ambassador for Beyond Blue and Community Ambassador for Are You OK? Tony, you've become such a respected community leader for mental health in this region. I wonder if you can tell us a little bit about how you got here and what is the most critical issue to you in terms of addressing mental health issues from your perspective.
Thanks, Renee. I very much fell into what I do now, sadly in the aftermath of losing my younger brother to suicide. And at about the same time, I was very much going down that same path. And so it was quite a challenging time back then. But to do something positive in the aftermath of losing my brother Mick, with the support from counselling, visits to a psychologist, I thought, I'll try and do something positive in his memory. So I quickly identified the Geelong Football Club as a great vehicle to engage with, and spoke to Frank Costa, who arranged a meeting with Jeff Kennett, and very quickly we got up the concept of the Beyond Blue Cup to increase awareness and reduce stigma about talking about mental health stuff. So I kind of fell into a lot of the talking that I do nowadays off that start, and it was an interesting a meeting, particularly in the first instance with Jeff Kennett, that I'd love to share some of the things that were said, but often you've got to keep some of those things a little bit private. So I'm just trying to get up a slide share that I was just going to talk, that kind of illustrates a bit about where I come from the consumer perspective. Let's see. It's not playing, so I might have to revert to just talking. Basically, my space that I dance around within the mental health perspective is focusing on the issue of isolation, loneliness and disconnection with the solution of social connection, particularly that social connection through volunteering and mentoring. And I've found over time from my own experience, and then sharing a lot of experiences with other people, that simple act of volunteering, helping other people, can be a very powerful solution. And I use a phrase nowadays, the best exercise that you can do is to help someone else who's down to get up again. So that's not physical exercise, that's exercising what's between the ears here. And I try and share examples of how simple that can be as a mental health solution, as well as a society building solution, through my Facebook page, Connect to Grow. So hopefully you can see that over my shoulder there. And I encourage everyone to check out that Facebook page, where I share simple stories about the simple things that you can do to engage with others that basically have this really technical output, a warm, fuzzy feeling. I propose that if you can replicate that warm, fuzzy feeling on multiple occasions, that's a good alternative to, say, medication. And it's almost like the high you get from exercising too. So some quick examples I can give of engaging this kind of stuff. I currently volunteer with an organisation called L, the number 2P, which is helping kids from a disadvantaged background to go from the L plates to their probationary licence because their parents either don't drive or they just don't have a car, and that kind of scenario. And what I've found, the young bloke I'm helping with at the moment, 120 hours is a lot of time to spend in the car we get to know the person. So not only am I teaching him technical skills about driving, we talk. And it's amazing the conversations that have evolved from that. So there's an element of volunteering, mentoring. Yesterday, for instance, because we've had a 6-month break because of the COVID crisis, he was pretty fired up, and he said he wanted to do the Great Ocean Road. And I'm thinking, not quite sure if he's ready yet, but we had a crack. So we left Bacchus Marsh, Ballarat, near Cressy, I think it was, Inverleigh, Winchelsea, Lawn, then back up the Great Ocean Road. And you can see I survived the experience. It was a bit challenging in certain places, but it's just a wonderful thing. It's a fun thing to do, volunteering as a mental health solution, because not only are you boosting your own self-esteem and how you feel about yourself, you're helping someone else. So to me, that's a win-win situation. And another quick example I can give, where I spoke at the corporate presentation recently in terms of volunteering, I suggested the importance of volunteering after an emergency. And we all know how the east coast of Australia was pretty well wiped out from bushfires recently. There's so many people down there need a hand. And I was talking about, this is an option. The day after I did the presentation, the bloke sent me an email, said that exact organisation called Blaze Aid that you're talking about, I joined them. And this is what it did for me. He was in the middle of a real mental health struggle. His best friend had died of cancer. He's going through a marriage breakup, so everything was going wrong at the same time. And the intervention, going away and volunteering in the bush around the highlands of Gippsland, meant that he was smelling the roses. He met some new people, new social connections, and he credits that with turning around how he was dealing fully struggling from focusing on helping other people. So there's just a few quick examples, Renee, and apologies for not being able to get my slide sharing up.
That's okay. Thanks very much, Tony. I might ask you one of the first questions that came in from our registration form, and you've already covered this a little bit, but I suppose what can we do in our day-to-day lives to make a difference? And I suppose that goes from as individuals who all have various levels of mental health concerns through to community, and what can we do in terms of community to make a difference?
Yeah, well, I think I did, as you rightly point out, touch on that briefly. I suggest rather than being overwhelmed with the macro situation of how big the problem is and how many issues there are out there, forget the macro, focus on the micro, what you can do one-on-one yourself. Very powerful stuff. It's community building at the cutting edge of where the issues are, and the fun that you can have when you engage with other people who are like-minded can be incredible. And I'm just thinking of a quick story where I got involved with Rotary, volunteering up in Papua New Guinea, and sure, it's hard work, but where I was volunteering was only 80 kilometres from Kokoda. So I managed to tick off a big bucket list thing of working for a few weeks in a high school in a place called Popondetta, but then also having a whole day looking around Kokoda. So if you kind of explore volunteering, particularly in something that you've got an interest in or a passion for, it's a very powerful on-the-ground solution.
Thanks very much, Tony. I suppose, how can we best support our peer support workers, whether they be former patients or carers? How can we support them in the workforce?
It's a very important focus. I believe in the importance of care for the carer. So it's all right to say that you're a carer, but who looks after you kind of thing. So carers need to make sure they take a bit of time out, engage with other carers, because other carers will get what they're dealing with. And I know one of my girls is a psychologist, and she does a lot of heavy stuff, but it's always great to see that she does debrief at the end of the day. And so I hope I didn't jump over you there, Marta.
No, it's okay. I was just going to say that in my case, it was my mother who was, her own mental health was declining by, that stigma of not being able to connect with community. I encouraged her to go to a support group, so we went to one of the Barwon Health community support groups. Can you hear me? Yeah.
I can.
And so we did that for 4.5 years, and I took her every single month to go to that. And sometimes she didn't participate, she just listened, but that gave her strength in listening to others who were dealing with the same sort of emotions, the experiences, and in that collection of people with just that beautiful karma of everyone looking after each other and learning from each other's experiences, and in that wonderful empathetic sort of space, she just grew and grew and grew. And it also, that made me understand myself and what the family dynamics were, and I grew. So, you know, it's a beautiful sort of situation that we need to encourage carers to look after themselves and be within the community of other carers, because, you know, we know a lot and we're an amazing bunch of people, but if we're left alone, you know, it's a lonely world.
Thanks, Marta. And James, I'll just ask you a quick question before we move on to our next panel members. And this was another question from the registration questions. But it was, how important was peer support in your recovery?
Peer support was a game changer for me, Renee. When I connected with my peers at Grow, the empathy, the understanding, the challenge, the support, collective wisdom of a group of people that have been through a lot of challenges themselves, it helped me to connect with personally growing and healing, and it challenged me into a bit of action. The Grow movement has a program that it uses that was, I could use that as a guiding light in my recovery. Has a lot of wisdoms and insights and attitudes which I put to work and applied and benefited from. So peer support, people understand each other and support each other really uniquely and wonderfully in peer support, and made the difference in my recovery.
Great. Thank you, James. We're going to move on to the other panellists now, but we'll did you want to say something, Marta? No? Okay. So, but look forward to coming back to you when we open the entire panel up to more Q&As. So our next panellists have extensive experience as clinicians and researchers in mental health in the Barwon region. So I'm pleased to introduce you to Associate Professor Stephen Moyland and Professor Michael Burke. First off, Stephen is the Clinical Director of the Mental Health, Drugs and Alcohol Service at Barwon Health. Steve, can you give us a little bit of your background? What's your vision for CHIME, and what's your vision for the mental health services for the Barwon community?
Sure. Thanks very much, Renee, and thank you for everyone for taking the time on this Monday evening. So as Renee introduced, my name's Steve Moyland. I'm the Clinical Director of our mental health services here at Barwon Health. I'm given the sort of great privilege of leading a team of 450 people who work each and every day to hopefully partner with people in the community to help them feel better. I'm a psychiatrist by training, and obviously I've done lots of work with individual clients myself and still do. And also I've had the benefit of doing research with Michael Burke over my period of time as well, and it's great to have my mentor in research here as my fellow panel member. One of the questions that was posed to us for this webinar was, what are the key elements that need to be addressed to really move our mental health system forward? And I wanted to focus on two key things which I've identified in my time working in mental health, which I think are really critical to answering that question. The first for me is, how do we truly understand the value that people who seek out mental health services, the value that they're desiring from those services? How do we truly understand what is being sought from that? The second question for me then is, particularly as a service lead, is how, after having a go of understanding that, do we harness the collective wisdom around us from our consumer group, from people with a lived experience in the past, from our clinicians and academics, and from the science, and from our broader community, to develop a service system that has a better than even chance of producing that value going forward. And when I reflect in my role here in running the service, what I know is that actually many people get a very good service from the system, and they would communicate actually they get a lot of value out of the services we provide, whether that be the clinical services, the lived experience support, whatever that may be. But equally, there's a group of people who are dissatisfied from the services they provide. And I think that inconsistency in what we are seeing from people reflects, I think, a confusion or at least a not complete understanding of what people are seeking when they are seeking out mental health services. And I think this lack of clarity has led to a whole bunch of issues in the system. And I think when we naturally are presented with problems that may come out of a lack of clarity, one of our system responses can be to, let's find something new. What's going to be new that we can develop that could fix that particular issue? And what we've seen, I think, in mental health over a long period of time is the development of lots of little new things. And there's little programs all throughout, which, whilst all really well-intentioned, has left our system to be quite fragmented and not well connected together, which ironically produces a further lack of clarity for both consumers of the system and providers to provide a good service. So in our deliberations of how we would transform our mental health services, I was sort of struck by a comment that I read about the pathway and the journey that Amazon took on when they were in their growth phase. And Jeff Bezos was quoted as saying that when they were getting around together to talk about where Amazon would go, there was a lot of talk initially about what new products or services they should be thinking about. How's the world going to change and what they should do? But as a leadership group, they actually resolved back around to say, taking into account all of those things, what are the key things, the key value things that our customers will always want, regardless of what the environment brings to bear? And what they resolved from that is a couple of things which they decided that irrespective of what happens, these won't change. And for them, they decided that customers will always want a broader range of options of things to buy, delivered cheaper and faster. And for them, they felt that if they could progressively work towards achieving those outcomes, a broader range, cheaper and delivered faster, their customers would continue to get more value from all the work that they do. And I actually really like this conceptualization because I think for a mental health service, we already know that there are some elements that people are looking for and will continue to look for regardless of what changes around. And at Barwon Health, we've conceptualized these into a few goals. And the primary one, which sort of feeds up, is that when people are seeking out support, they ultimately will want to feel better from the support that they receive. And when they're seeking that support to try and feel better, in the hope to feel better, they'll want those services to be accessible for them, so available when they need them, connected to the other care that they get, and provided to them in a safe and respectful way that also incorporates their family or community. So at Barwon Health, what we tried to do, working with our partners in the community, and we work with great partners with the Primary Health Network and a variety of community health organisations and the broader community, we really wanted to understand how we would do that. And there was a number of key questions that come up because of that. And one of those is the measurement of value. And secondly, there's also that, how do we institute a process of continual learning and progressive change? And really that's what CHIME is about. CHIME is about how can we bring together all of these bits of expertise so that we can learn iteratively from how we might improve each little element of our service delivery, that little bit, to drive towards that value, so that when consumers come through our service, they say that I feel even that touch more better, and I felt that the services were delivered in a more respectful and a safer way than they were before. And my journey was more accessible and more connected than it had been before. And I think this is the way we've conceptualized the growth. So CHIME's role is really, how do we bring together all these threads? Because I don't think necessarily in mental health it's going to be one transformative step, although there have been some big ones. I think in this area it's going to be a series of small steps and small improvements over time, focusing back on what that core value that we're trying to create for people is. So that's why I really like this the idea of this webinar, and it can bring together those voices and many voices from the attendees to really start that journey of how will we make those incremental, progressive learning system improvements over time to, help our consumers feel better. So thanks, Renee.
Thanks, Steve. Professor Michael Burke is Chair of Psychiatry at Barwon Health and is a world-renowned mental health researcher at Deakin University, especially in the development of effective treatments for psychiatric conditions such as bipolar disorder. He is co-author on a soon-to-be published book on Convergent Psychiatry, ironically given this is hosted by the Convergent Science Network. So Michael, can you tell us a little bit about how you got to where you are, maybe what Convergent Psychiatry is, and can you perhaps tell us what that means for you as both a researcher and a clinician?
Well, thank you very much. I've been working in mental health for, three decades plus, and I've been passionate about trying to develop newer and better treatments for people with mental health problems. So the idea of convergent science, as I see it, is that the problems that we face in mental health are really complicated, and they're unable to be solved by any one person or any one discipline working within a silo. So we need to pull together a real diversity of people with mental health expertise and expertise in domains that people working to solve mental health problems can benefit from. So this could be as divergent as people with artificial intelligence, neural engineering expertise, epidemiology, lived experience, health services delivery, and we need to pull together a group of people to solve the major challenges that we face in mental health. And I don't think it needs to be stated that there are many gaps in mental health that we need to address. I've been working for many years on developing novel therapies because many of the therapies that we have for people with mental health disorders are really inadequate, and there's a desperate need for new therapies. The other issue that I want to mention is, which is part of the brief that we received, is what I think is the most important element that is required to transform our mental health system. And that for me is the missing middle. We speak a lot about the missing middle. So in the public system, we have great expertise, particularly in the low prevalence, high severity disorders like the psychotic disorders. And then we have, and that sits within the state domain. In the federal domain, we have outpatient care and primary care and outpatient psychiatry. And the group of people who sit in the middle are those who have problems that are outside of the remit of the public system, but they are too complex and too unwell to be managed effectively in the private system in primary care. For the most part, these are people with complex mood and related disorders, mood and anxiety disorders. So if I had a wish, it would be to create a network of mood disorders centers of excellence. If one wanted to dream up a name, I would call them blue sky centers, and they would be modeled not unlike Headspace centers, so funded by federal government, located in the interface between the public system and the federal system, where people would be able to be referred seamlessly from between the various silos that exist. One of the great problems that we have in the management of mood disorders is that it's really de-skilled. So the model that is often used is the largest volume of people managed by the people with the minimal expertise to manage this, but these are often really complex problems. The other thing that's worth saying about these problems is that they often are highly treatment responsive if one does it well. So the gains are great, the unmet need is great, and I truly would love to see a national network of blue sky centers set up to meet this massive missing middle. So I think I'll stop there.
Thanks, Michael. I hope you've got a trademark on that already, because I think that's going to take off at blue sky centers. Can I ask you what do you think are the most promising mental health treatments and technologies emerging from research at the moment?
Well, there's an array of really promising things happening. One of the things that's really hot is the integration of lifestyle elements into mental health. So that's physical activity, nutrition, sleep, and substance use. On the psychology side, there's a huge amount of energy going into digital interventions. So I think this is a very promising avenue. And on the biological side, I don't want to bore you with the various things, but there's a huge number of new therapies that are being explored. And hopefully some of these will be good enough to actually break it into the mainstream.
Great, thank you very much. Before we move on, I'll just ask you one more question, Steve. How do we involve frontline staff and consumers in the plan that the plans that you're putting together for CHIME without it appearing tokenised?
Yeah, I think it's a really good question, and I also saw a sort of similar related question, which came up on the chat before, and how do you translate things from a research perspective into clinical service delivery? And I strongly think it's about how you embed these two partnerships together in a culture of learning together. So I don't think this is something, this sort of iterative small, when I say small, I mean not large scale, but progressive change over time is something that ultimately has to be driven by the frontline workers. Because when we talk about consumers feeling better or a consumer's experience of care, really myself or Michael or other people who are 3 steps, maybe sometimes 2 or 3 steps removed from that process, there's not much we can actually do in that moment. In the end, the consumer's experience of care is what is brought in that moment between them and the clinician or the peer worker or whoever might be interacting with them at that time. That's their experience. So that group is vital to be engaged in the process of how we can help that group understand what's happening with the new research and how it can improve the delivery provide, how we can, in the generation of that new knowledge, so that there's a sense of ownership to that process. Because clinicians on the ground are really busy people and they're doing their best and bringing their heart to the process. So I think it's really about embedding and building cultures around research, the provision and bringing in of academia, having appropriate pathways for consumer feedback and carer feedback into that process that involves that consumer, which allows them to take all of that information and knowledge into their interactions with the person they're trying to help at that time. So it's not a simple process, and I totally understand that people would say, this is hard to do, bring in a new treatment or whatever it might be. I think it's really about setting the foundations that health services themselves and their delivery also need to be services which are about understanding and generating new research and building connections with community beyond just the clinical service.
Thanks, Steve. We'll move on to our next group. Thank you very much, both Michael and Steve, for those answers. As many of you will be aware, governments at the local, state and federal levels are increasingly recognising that the mental health system is struggling and that there is an urgent need for reform. This includes the recently released final report of the Productivity Commission inquiry into mental health and the anticipated final report of the Royal Commission into Victoria's mental health system expected in January 2021. Our next panel members, Dr. Ruth Fine, Mr. Alan Woodward and Dr. Simon Strafacci, are at the forefront of these reforms at both the state and federal levels. Ruth, as the first Deputy Chief Medical Officer for Mental Health, what opportunities can you see for transforming the system and delivering better outcomes for consumers?
Thanks, Renee. And the first thing I have to say, of course, is I hope there are lots of opportunities. But also I just did want to thank Steve very much for asking me to be part of this, which has been fascinating so far. And I congratulate Barwon Health and Deakin on the partnership and on your intentions. So clearly many people have touched on some of those opportunities already, particularly in relation to integration of academic work and involvement of volunteers, the bringing forward lived experience. So I'm just going to step back a bit and say that I think COVID has taught us quite a few things. I think we've developed some new ways of working thanks to COVID, if I wanted to try and find a bit of silver lining in that particularly nasty cloud. But I also think that the Productivity Commission, which was started a good 2 years ago, and of course the Victorian Royal Commission, which also started, when was it? November 2018 it was announced. So both of those things have worked very hard and I think consulted broadly, and they will develop, I hope, very well. The Productivity Commission has, and I hope the Victorian Royal Commission does, develop a really coherent and persuasive way for us to proceed, because I think mental health is replete with plans. We cycle them around again and again. So for me, two big things that I want to highlight are the system architecture. Michael referred to the missing middle, but really it's a muddled middle, and it's a muddled middle with bits of PHN funding and bits of state funding, and so the system architecture at the moment does not make it easy for what Steve described as us understanding what people value and what people want. The system architecture doesn't make that easy for people. There's not a clear way in, there's not a clear pathway through, and often you could even say that there's confusion and even duplication sometimes, with different things happening all over the place. So I think a really good state, territory, Commonwealth discussion on that system architecture and on who should be responsible for what and how they should relate, for me, is one of the most important drivers. But if you're going to come up with what the system architecture might be and what people might value and how they might experience that, then you also need, absolutely critically, a workforce that's fit for purpose. And as Steve highlighted, we've got many fine people who give their compassion and passion to their work every day. But I also think that we know there are difficulties with distribution. We know that there is difficulty with Better Access is a great program, but for many people it's not affordable because there's a big gap payment. For many people it's not easily accessible. And for many people, as Michael has highlighted, one-on-one treatment is not what that person might need. They might need assistance with their family. They might need support with social aspects of their life, or drug and alcohol aspects. And as others have highlighted, they may well benefit from hearing from people with lived experience. So I think my two big things, I reckon, would be the system architecture, and that of course comes back to funding and agreements, but also the workforce that is going to work in that system, so that we not only have people who experience the system better, but we have better outcomes. And I hope that doesn't sound too Pollyanna-ish for you, Renee, but I think there is an opportunity now to try and do some of that stuff. And I have to say, I think Barwon's a great area to have some pilots, no, I hate the word pilot, to do some of that really new service models.
Thanks, Ruth. And I don't actually think it's too Pollyanna. I think that there absolutely is a complete opportunity at the moment to really make some significant changes here. So, Alan, I'll come to you next. And thank you, Ruth. And thank you for stepping in at the last minute from Christine Morgan, who was unable to come to tonight. As a commissioner on the Mental Health Commission, you've worked in this sector for more than 20 years in advisory, evaluation and researcher roles. So you really do represent many of the different perspectives being brought here tonight. So what do you think are the most important policy reforms for the Commission to address, and the opportunities, as Ruth has alluded to, that are ahead of us?
Thank you. Thank you for the opportunity to join. Very interesting discussion. Well, I think the most important policy reforms are always those that make a practical and a measurable difference to the lives of people. When the Commission was established, the phrase was coined to have a contributing life. That is, for all people to enjoy a contributing life and to support the mental health and well-being of the Australian population, so no one is left out. The initiatives such as Equally Well, which have flowed from the Commission since the start, also have addressed the importance of focusing on mental health as much as physical health and other aspects of quality of life. And more recently, we've looked at how we might achieve system changes And the Commission's role is very much one of looking across systems and seeing how they can be improved, revised, and sometimes through overhaul, essentially to deliver the bottom line, that is, practical and measurable differences in the lives of people. I guess I come to this not as a mental health clinician. My background is far more varied in social science, policy, business administration and communications. But I am a great believer in knowledge generation and exchange, because knowledge allows us to see how we can make changes that are beneficial based on sound information, but also through the exchange of knowledge to democratise that information, make it available and shared, so we can share the insights that expertise, evidence and knowledge can provide for us. Furthermore, I've seen the benefit of knowledge exchange through initiatives I've been involved in, such as research foundations and funds, where the knowledge obtained can be applied into service improvement on a continuing basis, linked to quality improvement processes. In other words, not to just see the system change as something that happens once in a while with an almost big bang scenario, but rather seeing that people individually, in groups and teams, communities and overall, can be engaged in a process of continual improvement. And we can use the data, the knowledge, the insights we have to do that. Fundamentally, seeking knowledge back from people who use the services and supports available to them for their mental health is the key to a sound and focused approach. And again, with the National Mental Health Commission, one of its roles is to solicit and represent the insights of people with that lived experience. So we have a consumer and carer survey. We provide an annual report on progress on mental health and suicide prevention system reforms, drawing on feedback obtained from users of services. And more recently, we've been undertaking a major step on what's called Vision 2030, create a 10-year plan for system reform. Commenced last year in 2019 with consultations all around the country, back in the days when we actually could visit and speak face-to-face with people in town halls and other venues. And now moving this year into the next phase to look at the roadmap and the specific ways in which the vision articulated through last year's consultations can be manifested. This time we're doing that more through an online survey. So I guess that's been my experience over the years, is that real change has to bring about practical and measurable improvements and differences.
Thank you, Alan. And Simon, last but not least, Simon is also a psychiatrist and has worked in mental health for more than 25 years, currently as the Chief Advisor for Mental Health Reform Victoria. Simon, can you tell us a bit about yourself, what Mental Health Reform Victoria is, and what transformation does Victoria's mental health system need?
Thank you, Renee, and thanks for the invitation. I'll echo Ruth's comments and just share my gratitude to Steve for inviting me here. It's always really impressive to participate in these activities at Barwon Health. I think the Chime initiative has so much promise for all the reasons that both Michael and Steve have outlined. So it's really great to be here. So Renee, as you've just explained, I'm a psychiatrist by training. I've worked for quite a long time now in the specialty. I've had the pleasure and the privilege, really, of having experience in both the public and the private mental health system, both as a clinician and as a mental health administrator, leader, etc. And I guess I sort of mention that because those two working in those different ways actually, funnily enough, does expose one to very different experiences. You know, working in public mental health, at its best, public mental health is about teamwork, and it's about multidisciplinary care. It's about managing complexity and risk. It's about really honing one's technical skills. At its worst, of course, it can be very impersonal. And we've heard stories of care that is traumatizing to consumers. Equally, private care allows one the opportunity to really engage intimately with consumers and their families in a way that is rarely possible in other settings, and I think it allows one to really get a much clearer sense of the drivers towards that contribute towards recovery and what Alan described as enabling a contributing life. So we've come, to the we're living through extraordinary times for a whole host of reasons, but of course, at the moment, we're going through this massive period of reform, what with the Royal Commission into Mental Health, the Productivity Commission into inquiry into mental health, the Aged Care Royal Commission, and all of the work that's being undertaken by the National Mental Health Commission. It really is an amazing opportunity, I think, for us. And for me, some of the things that have come out of that process is just the recognition. The Premier spoke of the mental health system being broken. I probably have a view that the system is designed perfectly to achieve the unsatisfactory outcomes that it's receiving, but either way, it's not delivering for the community. We recognise that. We've had to endure now decades of living with the soft bigotry of low expectations, to quote somebody much smarter than myself. And I think we've been challenged in recent years to really imagine what good looks like. And I think what we've discovered, of course, is that mental health mental health service provision does require us to deal with complex problems, and the solutions to those complex problems comes from divergent thinking that involves multiple perspectives. And I think what we're working towards then is a system that does actually provide a space for related. For people with divergent technical expertise, lived experience, clinicians, and people with various academic backgrounds to come together to really help to start to drive some of the solutions forward. In terms of what's required moving forward, I do believe that creating these collaborative spaces is really critical, and I absolutely endorse almost everything that's been said so far. I think what's perhaps been left out is the importance of leadership and organizational change and cultural change, because I think these will be drivers to the kinds of for the kinds of changes in attitudes and beliefs and practices that are going to be required for us to develop contemporary mental health services that will deliver for people and that will provide for the continuity of care, that will provide for the engagement with the issues that really matter to consumers, that will bring together both technical expertise and the expertise of lived experience, the focus on social determinants, the focus on recovery and on trauma-informed care. We need multiple perspectives, and we need leadership that is going to help facilitate that and drive that forward. I'll just pause there, Renee, because I could talk about this forever, but I'll just vacate the floor for some questions and answers, perhaps.
Thanks very much, Simon. Really appreciated. I guess one of the questions that came through a lot of the registrations was really about streamlining mental health services and how they can be streamlined. There was a comment, my experience both personally and professionally have found direct access to help difficult to obtain. Would any of you like to comment on this issue of streamlining and access to services?
Perhaps if I could say something. I think one of the outcomes of the Mental Health Royal Commission here in Victoria and certainly a commitment that's been made by the Premier is to respond, is to implement all of the recommendations of the Royal Commission, and there is an implication there of a significant uplift in resourcing. And I think it has to be said that part of what impedes access, of course, it has been historically an inability of services to meet demand. And to meet demand, appropriately with all of the depth and the continuity and the sophistication that mental health problems truly deserve. Once we do have with that kind of a commitment, and I think we'll see the Royal Commission will produce some recommendations that will address issues like system architecture and so on and so forth. But we will, I think, be moving towards, certainly there's been a lot of discussion within the Royal Commission, and we've seen it in the witness statements and some of the evidence that's been provided to the Royal Commission. We will see a focus on access, a focus on streaming, a focus on on services being able to provide, stepped care responses, different kinds of responses. We want to move away from a one-size-fits-all, and we want to move towards a system that is able to cater to the variety of needs that individuals have across the spectrum of age and across the spectrum of regional and metro sort of settings.
Great. Ruth or Alan, have you got anything to add?
Look, I'd add a couple of things. I mean, I think in many ways one of the problems we have is that there's many points of access at the moment. There might be different points of access for different ages, but there are many points. There's your general practitioner. There's Headspace if you're a younger person. There's emergency departments. There's triage, and in Victoria there's multiple different triages. And I think one of the problems has actually been beyond access. How do you access and then get the level of care for the duration that meets your particular circumstances? And I think this comes back to what Simon just talked about, that I absolutely believe that there will need to be increased investment in order to create the capacity to meet the demand. But I don't think it's as simple as adding on another service sector. I don't think it's as simple as another phone line. I think that in many ways people with mental illnesses have more complicated and multiple accesses than for most other health problems. If we're going to categorise mental illness or mental health problems as a health issue, then the access point is your general practitioner, and everyone sort of knows that. But we don't have that in mental health for a range of reasons. And for me, one of those reasons is that there's been such separation between what the state funds and what sort of Commonwealth funds, and then such a muddle about how that gets organised. Access is clearly an issue, but we have to say access to what, and how do you know which is the right access?
Yeah. Thank you, Ruth. Alan?
I'll probably just add, I guess, I agree with all that has been said just now, but maybe to add an extra dimension to it, and that is really the challenge of access, points of contact, and pathways through to care has to ultimately be very locally sorted, because that's where people are. They're in communities, and as Ruth was indicating, the GP, for example, is a critical point of access and should be. And there are other local points of access where we have digital services, telephone, online, text-based services. They need to be able to relate to what's in a person's locality. And I think this is where this challenge of trying to look at how you can get enough consistency and quality or standard of service across the country as a whole, so no one sort of gets a second best go at things, while at the same time having enough flexibility for there to be regional variations in how things are configured, match the needs and circumstances of the region. And I guess I come to this with a particular perspective because I live now, and I've lived most of my life outside of metropolitan areas. So I currently live in my home region, which is on the south coast of New South Wales. And I know what works in terms of how services can be provided to people and how access points can be improved on the south coast of New South Wales. is different to Western New South Wales and is different to the south coast of Victoria or to the in far north Queensland. Because Australia is a big country with different geographies and setups, and people have different socio-economic profiles in regions. There are different even geographies around how people move around. I think these are some of the challenges we face, and we've seen some of this mentioned in the Productivity Commission report. It's one of the issues that the National Commission wrestles with. And again, coming back to my earlier point, we ultimately need to find ways of providing services that are actually practically useful for people. And some of that, I think, is more attention to asking people how they find those services useful to use, looking at what the knowledge or the data is telling us about where people are using services, where they're going to, and the linkages sometimes between the mental health services and the other services that people might be seeking for help around their employment or their relationship issues or their personal finances. So I think it is going to require far more, in some ways, innovative approach. And the work that you've got now going between Deakin and Barwon Health is one of the ways in your region, I'm sure, that you will harness some of the innovation. I've seen it in my region between the University of Wollongong and the regional collaborations, when people can find amazing solutions to some of these challenges. But I think that's going to be one of the real things as we try and improve the system.
Great, thank you very much, Alan. Now I'm going to open up the questions to the whole panel, but I think the first question that's been asked here that's had a lot of likes and I think is quite relevant, I might direct specifically to Steve and Michael, and I'll read it out for you because I think it's a great question. Translating research findings is often a difficult process, irrespective of the area. Mental health strikes me as particularly difficult in this regard, though. How does CHIME intend to ensure its research findings are appropriately translated into clinical settings? Steve, did you want to comment on that?
So Renee, I commented a little bit on that one before, which is really about that culture. But what I might do actually instead of going to that is I might ask Michael a little bit about, in his experience over time, what have been the this practice improvements, the kind of new science that he's seen successfully implemented, and what do you take out of that?
Well, I think that the question is a very important one, and I think we all know that the gap between definitive evidence appearing in a journal like the New England Journal and practice changing is a decade plus. So evidence is very, very slow to percolate into clinical care. Now, this is where I think the way that CHIME is structured is so important, because CHIME is structured as what we've spoken about as a learning healthcare system. So it's a system which generates evidence, evaluates the evidence, and is able to take what evidence is generated and rapidly and effectively integrate it into care. So it's not only evidence that is generated by the research that's happening here, but we want a system that is able to be aware and be abreast of where the cutting edge is and what best practice is in terms of clinical care and health service delivery, and ensure that this is translated into clinical care. But at the same time, we want to allow the service to embrace and participate in the generation of new knowledge. So to generate a circular learning healthcare system which simultaneously generates evidence and implements it into clinical care. That's the vision of CHIME, and the hope is that this is really going to be a transformative system that'll provide a quantum improvement in patient care and the clinical experience.
Thanks very much,
Renee,
Michael.
I might just jump in and add one more point to that.
Yep.
Sorry, Renee.
Yeah, that's okay.
I was just going to say that I think one more important point for everyone to understand as well is that evidence is evidence. Like, evidence gets produced, but one of the most important things is actually applying that evidence in the context that you are in. And it's just a really important thing that we have to develop health systems. And I think, going to Simon's point, health systems to have appropriate leadership and skills in change management to actually integrate those things together, but also to complement Alan's point, that understand the localized context. Because there's absolutely no point in putting in a system of care that works really well in Boston if that's not going to be a context that's going to work well in our local area. So we have to have the capacity and literacy in understanding these things to both understand what are the lessons out of that new science that's produced and how are they applicable in our local area from the context as we understand it. And I think that's one of the really important things that I think all systems in terms of improving care need to get right.
Thanks, Steve. I'm going to change tack a little bit here now and maybe go to you, Tony. I just lost the question that I was going to ask you. Tony, this question is from Tony Van Hammond, who said, schools, bars, hairdressers go where the people are rather than expecting people to come to you, which equals access, and then allow services to work where the person is most comfortable, need innovation and thinking outside the square to bring about change. Tony, I wonder if you can reflect on the work that you've been doing in bringing support services and community leadership into some of our workplaces. In particular, I believe it's the construction workforce at the moment.
That's a very astute question from Tony Van Hammond, who I blame her for getting me involved in Headspace. So thanks for that, Tony.
I didn't even know that.
Very relevant example, Renee, I can give is where I work in the construction industry. The idea was to tackle the high suicide rate in that sector. And it was a bit of a suck it and see approach. When I first went there on building sites, we said, okay, let's set up in the first aid hut and see what happens. Well, no one was knocking on the door. So we very quickly came to the conclusion that just go out and talk to the lads. So I've got what's called a white car, which lets me wander around, pretend I'm a tradie with helmets and boots and fluoros. I just literally start conversations with people. And what it opens up is some amazing stuff and some really simple solutions. Like one guy at one construction site was basically being bullied, really tight deadlines, no love from his bosses on that site. But he did mention in conversation that he had a good relationship with his old boss on the old construction site, same company. So I said, well, why don't you have a chat to your old boss if you're getting nowhere with your new boss? And that became a very powerful solution. They had a conversation. They both realised they enjoyed a bit of work and walking in the bush, that kind of stuff. So the old boss had this other bloke go out within one Sunday and spend 3 hours chopping firewood in the bush. Just a simple intervention where they spoke about stuff. And you can't solve a lot of these things overnight, but just to download to someone else is a very powerful first step, rather than just, if we didn't have that conversation, he would have been building and building up his internal tension with the growing deadlines that are happening on the construction site. So yeah, just try and keep it simple. I find a lot of the guys on the construction sites are dealing with what I call situational distress. They're not kind of mentally ill per se, but if they're single or they're working 6 days a week, they're just overworked. They're tired. They've got no time for other interests. Throw into the mix the construction worker who is a fair chunk of them have got broken relationships, so they don't get to see their kids regularly, or they're in a family law dispute where they're arguing with the ex about access to the kids. It's almost like a tinderbox about to explode on a lot of the sites because just the huge frustration. So, like I said, they're not mentally ill, but if they don't talk about what they're dealing with, they will very much head down the path of mental illness if they don't reach out and ask for help. And particularly, I highlight there's an employee assistance program on site. In the smaller companies, particularly in the private sector, often they don't know what an EAP is. And it gets back to the basics of that first step too, of the entry for help is just simply talking to your GP, and they will open the door. So I went off on a bit of a tangent there.
No, that's okay, Tony. It's probably a good segue into the next question, which I might direct to you, Ruth, which is, do you think we'll ever get to a point where a regular checkup with your GP will involve screening for mental health concerns in the same way it might involve testing someone's blood pressure or cholesterol?
Well, I don't know the answer to that. And of course, one of the problems that we often have is that there is not an objective, there's not an objective scale that says, are you mentally healthy or not? Although there are screening tools like K10s and HONOSs and all sorts of other things. But I think a couple of things I'd add here. I do think that increasingly we need to help general practitioners be aware of the need to start that conversation, the need to explore how someone is feeling and relating, not just what symptom are you presenting with today. I think GPs do recognise now that a very significant proportion of people who present to them perhaps with a physical problem are in reality coming about a social or a mental health problem, and so I think there is a sort of a need for both training. But the other thing I think is that the system as we have it in GP land isn't really designed for mental health presentations. It's a throughput system, and it's often a system with very short appointments, and that particularly in bulk billing practices that can drive exactly the opposite of what you just talked about, Renee. So I do think there needs to be a number of changes before we get to the point where you might say that there is some checkup, if you like, of a person's mental health as well as their physical health when they present to their GP, regardless of what they present with. Mind you, not every GP takes your blood pressure every time you go either. So, it's we ask a lot of our GPs.
Thanks very much, Ruth. So maybe for Marta and James, we've got a question here. What do you think needs to happen in the lived experience space for carer and peer workers? I didn't know it existed until I was in the system. And how do we get this out to the wider community? And I know you both touched on this a little bit in your introductory session, but I suppose how do we get out to the wider community this experience and peer support workforce, what it does and the benefits of it, and how do we support it?
I think at the moment in Barwon Health we've got a few different areas in peer support. The area that I'm a part of is post-discharge peer support, and that is where we meet people in the Swanston Centre, connect with them there, start the peer relationship, and then ongoingly engage in peer support together when the person is on the ward, and also when they return home or to park or wherever they're going in the community. So that runs, it's called a 28-day post-discharge peer support initiative, trying to reduce the amount of readmission in that first 28 days. That's one peer support program that we've got going at Barwon Health at the moment. We've just recently had other programs, peer personality program, where people with a personality disorder, the novel, innovative approach that we're taking at Barwon Health to engage these people with peer support. A thing called Peer Zone, which was run by Mary O'Hagan from New Zealand. Some people might have heard of it. And that's recovery run workshops and engaging people with peer support. There'd be 2 recovery support facilitators and maybe a group of 8 to 10 people. That's another type of peer support that we've got going. We've got one other general peer zone program happening at the moment. In the community too, there's things like GROW. GROW is a peer support mental health movement. It dates back to 1957. Things like Mindworks in Geelong, that is mutual support, self-help, and people. It just creates a supportive, non-judgmental, safe community, and where people can grow. Because at the start, the recovery journey, connecting with the wider community can be daunting. We can at times be not quite ready for that, and we need to make those mini steps along the way. So, yeah, peer support, I see it as a movement that's growing, and I think the Royal Commission in Victoria recently highlighted as one of the recommendations that the lived experience program will expand in time. So that's some peer stuff. Marta, do you have some family peer or carer peer?
I think for me, it's about educating the whole community about what we do and what we can offer. Everyone knows what a nurse does. Not many people who I've come across know what a peer worker does. So, it's just about having a bigger workforce so we can offer it to more people, and in that way we can help more and more people, and it just becomes more of a community aspect. Because everyone in a puzzle, consumers, carers, clinicians, community, all come together to connect for the one goal, which is well-being. So, if we don't educate people and there's not enough of us, then, we're just a thing in that puzzle that could be missing, that doesn't, finish that puzzle off. So, to me, it's let's have more of us and educate people of what we can offer.
Renee, if I could just say something. Last week, the Victorian government announced that it was going to include about $16 million of spending in the budget this year in order to grow the peer workforce. And that's a really substantial investment. Insofar as its aim is to create, not just to expand the peer workforce, but to create a structure within the peer workforce of junior and senior positions, enhancing developing peer supervisor positions, introducing cadetships and coaching opportunities, etc. So I think we are going to be seeing, this is following on from the recommendation in the interim report of the Royal Commission, as James referred to it. This will be this will really give life to that recommendation, and we'll see some fairly serious investment in the future of the peer workforce. And that was announced last week.
Thanks very much, Simon. Unfortunately, we're now running out of time. We've got so many questions left. As I said earlier, we will try to respond to some of those questions through a frequently asked question format that we posted on the Chime website. So I'm very sorry about that. We could probably talk about this all night. But I'd like to thank you for your time and engagement tonight, and especially thank you to our panel who have all been very honest and generous with your time. I'm now going to ask Professor Julie Owens, who is Deputy Vice-Chancellor of Research at Deakin University, to say a few closing words, and after that, Luan Ismail will close the event. So thank you very much, everyone, and over to you, Julie.
Thanks very much, Renee. So this evening's event's been a great opportunity for the community, our consumers and carers, organisations focused on supporting mental health, and many others, including researchers, to come together and discuss the most pressing issues that concern us all in mental health and wellbeing. As Francis noted at the beginning, it's also been a really important opportunity for Chime, the new partnership between Barwon Health and Deakin, to hear from those consumers and carers and others to really further inform our collective approach to better design and production of more effective models of care, treatments and therapies to really make a difference for the Barwon region and we hope in future to take our learnings more widely across Victoria, Australia and beyond. Now, as we highlighted earlier, we want to remind everyone that any of the discussion this evening, if it has raised issues for you, the contact details of where to go for help are available on the chat function. So now, on behalf of us all, I want to thank our panel members, certainly the Convergent Science Network, and you, the audience, for your participation and contributions this evening. I'll now hand over to Luan to close the event. Thank you.
Thank you, Professor Owens, for those concluding comments and for Deakin University's partnership with Barwon Health to meet the challenges of mental health care in the Barwon region. Well, what an amazing discussion. I hope many of you found this event worthwhile, inspiring, and will serve to continue your interest in mental illness and mental health care. We've had a wide-ranging discussion, and I'd like to express my very sincere thanks to all our panel members for their contributions and commitment to participate in this important public discussion. I thank them for the work they do and wish them continued success in their endeavours. And finally, I wish to thank a number of people who have made this event possible. Anna Burgess of Barwon Health for her enthusiasm, commitment and support. To Renee Carolyn for her extraordinary organisation and her expert moderating. Thank you, Renee. To Celia Vanderstadt for her incredible behind-the-scenes support. And to Catriona Wynne Robertson of the Convergent Science Network for her social media support. Thank you, everyone, for joining us for this event. Stay healthy, stay safe. Good evening.